Assalamu alaikum and welcome to the Medical Black Book. Our today's topic is shock and blood transfusion. Shock is a systemic state of low tissue perfusion with insufficient delivery of oxygen to the cells. Now, considering this in a normal cell, it receives its energy through a pathway known as aerobic pathway, which means it utilizes oxygen to form its energy. The byproduct of this pathway is carbon dioxide. The carbon dioxide exits through the body by basically first entering into the circulation and exiting through the respiratory pathway, in which what happens is we inhale oxygen and exhale carbon dioxide. When there is a state of low tissue perfusion, the body has officially entered the state of shock. In this shock, as there is no oxygen, these cells shift to another metabolic pathway, which is anaerobic pathway. In this, the byproduct formed is lactic acid. This lactic acid also enters the circulation, but rather than exiting out through the respiratory pathway, it results in acidosis. Hence, by decreasing the pH, normal pH of the blood, which is 7.4 to less than 7.4, when this happens, this acidic phenomena activates a lot of stuff, such as the complement and the neutrophils. The neutrophils, when they are activated, they release reactive oxygen species as well as cytokines. These cytokines function on the endothelium of the blood vessels, making it leaky, due to which the plasma which is present in the blood starts to leak out from the circulation into the tissue, which results in worsening of the cellular hypoxia. At the same time, you also know that glucose is an essential product which is used by the cell to generate energy. This glucose acts on the sodium potassium pump, which is present on the cell membrane, making a concentration gradient which results in providing energy to the cell. When no energy is created in the cell, it starts to die off by releasing autodigestive enzymes secreted from the lysosomes. When these cells die off, the intracellular content or the electrolytes present is released in the circulation. As you know, the potassium concentration inside the cell is a lot more comparatively to the extracellular space. When this concentration increases to a sufficient amount, this potassium can also be harmful and can even lead to cardiac arrest. This shock does not only affect a simple area because it affects all of the cells. Cells are made tissue and tissues combine together to make organs. So it affects various organs such as in the cardiovascular system. Because all of the fluid is leaked out from the circulation into the tissues, there is insufficient amount of blood present in the circulation, which decreases the blood return to the heart, resulting in decrease in preload. If there is no blood present in the heart, obviously it will pump out less, meaning decrease afterload. This is sensed by various areas of the body, such as the beta receptors present in the carotid artery and as well as in the adrenals, which secretes sufficient amount of hormones such as aldosterone and catecholamines, which elicit a sympathetic response, resulting in vasoconstriction as well as tachycardia. In the respiratory pathway, we know because of this anaerobic respiration, lactic acid was formed which entered the circulation, creating acidosis. Now this is not a normal phenomena, so the respiratory pathway and the kidneys try to compensate for it. In the respiration, the respiratory rate increases as well as the ventilation, which results in excretion of the carbon dioxide, resulting in an alkalosis. This alkalosis is compensated by the kidneys. In the kidneys, because of the vasoconstriction caused by the catecholamines, results in decreased kidney perfusion. In a state of shock, only 3 areas are well ventilated with blood. This includes the brain, the heart, as well as the adrenals. The rest of the body, because of the vasoconstriction, the blood supply to them is decreased. This decreased kidney perfusion results in activation of renin because now it wants to compensate for its own blood supply. This activates the renin-angiotensin pathway and similarly results in more vasoconstriction and sodium and water absorption. At the same time, because the body is in a state of stress, the adrenals release another hormone known as cortisol, which also causes further sodium and water absorption. You think now this now if we return the blood supply to the body, this will compensate for everything, but it actually doesn't. It causes ischemic reperfusion syndrome. In this syndrome, what happens is before perfusion, there is increased concentration of potassium and lactic acid into the circulation. This enters the heart and affects the myocardial cells, causing them to contract. When the perfusion is restored, oxygen is carried to these heart muscles. This causes these muscles to further contract, resulting in myocardial damage. When these muscles contract, there is circulation of the blood, as well as this blood consists upon neutrophils and complements. When these substances are flushed into the circulation, this results into organ failure because these neutrophils cause damage to the normal tissues, and the complement further results in coagulation of the blood supply to these organs, resulting in organ failure. Types of shock. There are 5 types of shock. The first one is cardiogenic shock. This is caused because of the failure of the heart's pumping ability. The heart pumping ability can be affected by conditions like myocardial infarction, in which some of the cells of the heart die off because of their decreased blood supply. Or it can also be due to volume loss, which can be affected by dehydration, such as caused by burning, or any problems such as hemorrhage, or it can be due to hypertrophic conditions occurring in the heart. Along that, a blunt injury to the heart can also result in cardiogenic shock. Our next shock is hypovolemic shock. This can be caused due to hemorrhage or non-hemorrhagic phenomena. In hemorrhage, there is acute blood loss. In non-hemorrhagic, it is caused by dehydration, which results in decrease in plasma level, as well as third fluid loss, in which the blood from the circulation enters the tissues, resulting in decreased amount of plasma volume, resulting in decreased blood volume that is received by the heart. Diabetes mellitus, in this, due to increased urination, results in decrease in plasma volume. Hence, the patient goes into a hypovolemic shock. So in such patients, they should receive adequate amount of fluid in order to not be affected by such a shock state. In obstructive shock, there is a decrease in preload due to mechanical obstruction. This obstruction is caused by cardiac tamponade, in which there is blood accumulated in the pericardial space, which inhibits it to contract sufficiently in order to supply the blood to the body. Tension pneumothorax is another condition in which the air is accumulated in the pleural space, which presses upon the heart. Similarly, it hinders its function to contract and supply blood. Similarly, an air embolism can block the circulation as well as the pulmonary embolism. In a distributive shock, this is also known as a shock that is caused by any form of energy, also known as anaphylactic shock, and this can also be caused during a spinal cord injury. In this, what happens is anaphylactic shock, there is increased release of histamine, serotonin, and other vasoactive amines, which causes vasodilation. So in this shock, what happens is there is increased amount of vasodilation occurring in the body, due to which the heart does not receive any blood. In all of the shocks, the peripheries of the body of the patient are cold and the blood pressure is decreased. But in such distributive shock, the peripheries are warm because there is increased amount of accumulation of the blood due to vasodilation. Because of this vasodilation, there is hypotension created in the body. Because the heart does not receive sufficient amount of blood, the cardiac output and the afterload decreases. In endocrine shock, this is caused due to a decrease in specific amount of hormones, such as if there is adrenal insufficiency, there is decrease in aldosterone as well as cortisol and catecholamines. This causes a dysonian crisis in the body, in which the patient is hypotensive and dyspneic, and the blood pressure has gone very down. Other cause is thyroid disorder. This can be either hypothyroidism or hyperthyroidism. This both affects the vascular as well as cause cardiogenic response, which leads to bradycardia. Now, the grades of shock. The shock can be either compensated, mild, moderate, or severe. This is graded upon specific criteria such as pulse, lactic acidosis, urine output, conscious level, respiratory rate, and blood pressure. In a compensated, the pulse is mildly increased, there is lactic acidosis, the urine output, conscious level, respiratory rate, and blood pressures are all normal. In a patient with mild shock, the pulse rate is mildly increased, there is lactic acidosis is more, the urine output is normal, the patient is in anxiety, the respiratory rate is increased, and the blood pressure is normal. In a moderate state of shock, the pulse is still increased, there is lactic acidosis, urine output decreases, the conscious level is the patient is in drowsy state, respiratory state increases, and the blood pressure, there is mild hypertension, approximately 149 mmHg. In a severe state of shock, the pulse rate is still increased, there is lactic acidosis is a lot more, the urine output, there is no urine being produced, hence anuria, which means absent urine. The patient is comatose, the rate of respiration is basically labored, and the blood pressure, there is severe hypertension, it is approximately more than 159 mmHg. Now, in such a patient, how to restore it? We knew that there was no oxygen, no energy supply. So if we give fluids, or we resuscitate the patient, or we give sufficient amount of oxygen, maybe we will reverse this state of shock. This phenomena is known as resuscitation. So when do we start resuscitation? We start resuscitation when the pulse is decreased, the blood pressure and the pulse has increased, the blood pressure has decreased, and the urine output also has decreased or is absent. When we start patient on fluids, there is a phenomenon known as occulted hyperperfusion, in which the vitals have become normal, but there is persistent acidosis and low mixed oxygen saturation. So such a state is known as occulted hyperperfusion. So by giving more fluids or the sufficient amount of blood, we can restore such a state or make the patient normal. If the patient is in this state for more than 12 hours, there is a 3-time risk of patient of dying from this shock. Now, the steps of resuscitation. There are basically 5 steps. The first step is conduct of resuscitation, fluid therapy, vasopressin, and inotropic support. Fourth is monitoring, and fifth is additional modalities. Now, the conduct of resuscitation. The first thing when you receive a patient in shock is to identify what type of shock is it. So treatment could be according to it. If you cannot identify what type of shock the patient has, we can consider it as a hypovolemic shock. And after knowing this, we quickly administered high dose of fluids after first controlling the bleeding site. Then we start on fluid therapy. Most of you will think if we give certain amount of inotropic drugs, chronotropic drugs to the heart, if the heart pumping ability will be improved, there will be more blood given to the circulation. But that is not true. Inotropic drugs stimulate the SA node, stimulate its firing, hence the heart contracts more, and the chronotropic drugs cause ventricular contraction. By doing so, if the blood volume is already low, you will empty the heart faster, and due to such increased amount of contraction, you will also deplete the myocardium of its oxygen supply. Similarly, the coronary vessels would also constrict, hence decreasing its supply to these organs. Similarly, the heart would also die off if you you start off with these 2 drugs. So before doing such a thing, first you need to do is you need to restore the volume that is being lost. Then you have to give these drugs to boost the heart rate or to boost the heart contraction to supply more blood to the rest of the body. The fluid that is being given are colloids or crystalloids. Colloids, example is albumin, which is it's a plasma protein. It binds the water content that is present in the plasma, so it is not leaked into the circulation. This is also helpful when the patient is having an inflammatory process going on. So this retains basically the fluid volume inside the vessel and prevents edema. Then we have crystalloids, which consist upon basically fluid and electrolytes such as Hartmann solution and Ringer lactate. Now this has albumin is very hard to get, so it is very expensive and it has worsening side effects. Whereas in hospital solution, this is commonly used in every hospital and it is very cheap and does not have any specific side effects. These fluids do not have an oxygen carrying capacity, so in order to compensate for oxygen carrying, we need to administer the patient with blood. Now, how do you know that your fluid is working on that patient? This is just determined by cardiovascular response. In cardiovascular response, we assess the blood pressure after every 15 minutes, heart rate, and central venous pressure. The fluid that is being given to the patient is approximately 250 to 500 ml over 5 to 10 minutes. Then, after 15 minutes, we assess the patient, and the patient is classified as a responder, transient responder, and non-responder. If the patient condition improves and the serious response is sustained, such as blood pressure, heart rate, central venous pressure, we consider this patient as a responder. If it is improved, but the patient reverts back in a state of shock after 10 to 20 minutes, and there is moderate ongoing loss, we consider this patient as transient responder. In a non-responder, even no matter how much of fluid you give, there is still the blood pressure is still decreased, the heart rate is still increased, and the central venous pressure is still depressed. You can consider that there is another bleeding point within the body. It could be due to any sort of internal hemorrhage. Before you cannot revert this patient from non-responder to a responder till you control this additional bleeding point. And lastly, always remember hypotonic solutions such as dextrose should not be used in a state of shock unless there is free water loss. If the patient is in a state of shock because of water loss, such as a dehydration, which we have discussed as hypovolemic shock, then you can give dextrose to such a patient. This congestion can be caused by diabetes insipidus, in which there is increased intake of water and increased amount of urination by the patient because of excess amount of ADH that is being secreted by the posterior pituitary. Then sodium overload. Sodium overload causes retention of water in within the body, which can also lead to dehydration. This is seen in the patient of cirrhosis or end-stage liver disease. Then we have vasopressin and inotropic support. This vasopressin is given to a patient in distributive shock because there is vasodilation and that is occurring in the body that is resulting in this type of shock. So, and there is low systemic resistance. So by giving this, there will be constriction of such blood vessels, and by giving inotropic drugs, there will be increased contraction by the heart. Hence, this hypotension created in the body would be relieved. We can also give this in a cardiogenic shock because there is decreased pumping ability of the body. Along with these drugs, we can also give the patient dobutamine, which acts on the heart as well as the kidneys and the adrenal glands. Now, monitoring. Monitoring of such a patient is by ECG, pulseoximetry, blood pressure, and urine output. Additional modalities include central venous pressure. In the central venous pressure, when an IV bolus is given to a normal patient, the central venous pressure is increased more than 2 to 5 centimeters of water, but it returns to normal after 10 minutes of infusion. But in a state of shock, it never rises. Then another modality is invasive blood pressure and cardiac output. Cardiac output is invasively measured by pulmonary catheter and non-invasively by Doppler ultrasound. Then we have systemic aortic perfusion, and this adequacy of shock treatment is monitored by urine output and level of consciousness. Lastly, we have base deficit and lactate. Patients in shock have lactic acidosis. As we have already studied, the cells in an anaerobic respiration start to excrete lactic acid as a byproduct of that metabolic anaerobic metabolism. In a patient with a deficit of 6 millimolar or higher are at great risk of dying from that shock. Then we have hemorrhage. Hemorrhage is basically acute bleeding. Acute bleeding is not stopped by resuscitation. It is stopped by stopping the bleeding point. In a patient with ongoing bleeding, resuscitation have no use. Instead, it worsens the condition of the patient. How? Basically, if we infuse a lot of fluid and the patient is still bleeding, the coagulating response caused by the platelets would decrease because of the dilution of the fluid that has been caused by resuscitation. At the same time, in this state, the body enters a state of shock, which results in acidosis, Acidosis also affects these coagulating proteins, which further inhibits the process of coagulation of those injured blood vessels, resulting in acute coagulopathy. In such a patient, muscle energy also decreases, resulting in hypothermia, as muscles warm up the body by generating energy. Then different types of hemorrhage. Hemorrhage can be either revealed hemorrhages, which is visible hemorrhage. Example of this is open arterial wound, or hematemesis, which is blood coming out during coughing. Then we have concealed hemorrhage, in which is inside the body, such as a retroperitoneal bleeding or a long bone fracture. In a long bone fracture, such as if the femur is fractured, there is a circumflex artery which is being supplied to it. During such avulsion of such artery, there is a large amount of fluid being lost within that area, which is concealed, and due to which patient condition deteriorates. In a primary hemorrhage, this is an immediate hemorrhage whenever there is injury inflicted onto the patient and the patient starts bleeding. This is known as primary hemorrhage. Reactionary hemorrhage is delayed bleeding after 24 hours. This delayed bleeding is due to dislodgement of clot from the circulation, which has previously occulted that blood supply, and later when this dislodges, the blood starts to ooze out from the avulsed area, or when the blood pressure normalizes, because in a state of shock there is vasoconstriction going on all over the body, because increased amount of catecholamines are also secreted. When the concentration decreases and the blood pressure normalizes, the blood is being restored to all of the body. Similarly, through such areas bleeding begins, or it can also be due to vasodilation. In secondary hemorrhage, there is bleeding that is occurring after 7 to 14 days after injury has been caused. This is due to slouching of the vessel's wall. This slouching of the vessel wall can be caused by either infection, pressure necrosis, or malignancy that later on erodes the vessel, and similarly bleeding occurs from that area. Then we have classification of hemorrhage. The stage, it is divided into 4 stages based on how much amount of blood volume is lost. If it is 15% lost, it is stage 1, 15 to 30%, 2. In stage 3, approximately 30 to 40% of the blood is lost. In stage 4, more than 40%. In early hemorrhage, hemoglobin remains unchanged, but later, due to fluid shift in the intracellular interstitial spaces, hemoglobin and hematocrit decreases. How do you manage a patient with hemorrhage? First, we need to identify what sort of hemorrhage is it, or where the hemorrhagic area are present. Then after stopping the bleeding point, then we start the resuscitative maneuvers, which consists upon direct pressure to stop the bleeding point. If a large amount of blood is being lost, we give the patient large IV units of blood. But before giving the blood, we always need to cross-match it to inhibit or to stop any anaphylactic reaction caused in that body. And because the patient is in a state of shock, there is acidosis, and we need to prevent acidosis so that coagulopathy and hypothermia is not caused. Then, if the bleeding area is still not normalized and the patient needs surgery, we need to do damage control surgery, in order to arrest the hemorrhage, to control infection, and to protect from further injury. These are done to avoid physiological exhaustion. Now, in transfusion, what do we give? We give packed RBCs. This consists of approximately 330 ml of blood and has a hematocrit of about 50 to 70%. And normal hematocrit in an adult is approximately 35%. We keep these RBCs in a SAG-M solution, which is saline adenine glucose mannitol solution. This is a shelf life of these RBCs. You know, the normal RBCs die after 120 days, which is present in the body. But if you want to save it for about 5 weeks, we need to store it at 2 to 6 degrees centigrade. We can also use another solution, which is known as citrate phosphate dextrose solution. This can save the RBCs for about 2 to 3 weeks. Then we can also have fresh frozen plasma, which is also present, which is also a constituent of blood. We keep this at 30 to minus 40 degrees, which increases the shelf life up to 2 years. And this is the first line treatment in coagulopathic hemorrhage, in which there is blood coagulating proteins are decreased, there's increased ongoing bleeding, and the blood is not coagulating. Hence, we give such a patient fresh frozen plasma. We can also give patient cryoprecipitates, which consists of fresh frozen plasma along with factor 8, which is a coagulating protein, and fibrinogen. This is stored at minus 30 degrees, which increases the shelf life to about 2 years. Then we have prothrombin complex, which contains approximately 250 multiplied by 10 power 9 liter at 20 to minus 4 degrees centigrade, which increases the contains 250 multiplied by 10 power 9 per liter at 20 to minus 224 degrees centigrade. This increases the shelf life up to 5 days. This is given in a state of thrombopenia and platelet dysfunction. Thrombopenia is a condition in which the platelet number decreases, and platelet dysfunction is in which the platelets are not functioning properly. This is also given in heart patients who are on antiplatelets, and also well as on patients who are taking aspirin and clopidogrel. So, in such a patient, a continuous infusion of platelets is given during surgery in order to cut the blood that is inflicted upon cutting the body. Now, when do we start giving blood transfusion? This is given in patients with acute blood loss, pre-operative anemia treatment, or symptomatic chronic anemia. Complication of blood transfusion. In a single transfusion, the patient can have complications such as incompatible hemolytic transfusion. If your patient is A positive and you're giving them a B positive blood, so an anaphylactic reaction would be caused in such a patient. There could be febrile transfusion reaction, in which the patient after transfusion can have a very increased amount of fever due to infections containing in that blood. Any allergic reactions, infections, other infections such as HIV, if you do not screen it properly, hepatitis B, C, and cytomegalovirus can also be can cause later on infection in such a transfusion. There can be also air embolism if your catheter is not properly placed, and thrombophlebitis, which itself is air into the veins. Then if you give a patient with massive transfusion, the complications in such a patient would be caused are coagulopathy, in which the coagulating proteins are non-functioning or decreased, hypocalcemia, hyper or hypokalemia, which is decrease in potassium, hypothermia, and hemochromatosis. Because you are giving a lot of blood, there will be a lot of blood break time after 120 days or less, depending on how much the lifespan of the RBC is. So there will be increased iron, which is the breakdown product of the hemoglobin. That will be accumulating in the liver as well as the cornea and other systems of the body, resulting in a condition known as hemochromatosis. Then how do we manage a coagulopathy if this is occurring due to massive transfusion? We correct this. Correction is not needed if there is no active bleeding. If there is active bleeding, we give the patient fresh frozen plasma and we monitor the APTT and PT. This is given when APTT and PT is less than 1.5 times the normal. We can also give the patient platelets to coagulate any injury from which blood is oozing out. And we only give platelets if the concentration of platelets is less than 50 multiplied by 10 power 9 per ml. We can also give antifibrinolytics, which consists upon tranexamic acid and apoprotein, and recombinant factor 7, which is also helps in coagulation.